All right, we're going to talk about pain in chapter 4, and it's definitely an area, it's become basically a new area of study. What causes pain? What do we do about pain? And a lot of textbooks about, I think it was 2012, 2013, the new edition of the neuroscience textbook came out, and they had added a whole chapter on pain and pain as disease and pain matrix dysfunction. Well, this year we have a new edition of our pathophysiology book, the 6th edition, and they added this new chapter on pain. And I think it's great because pain is the symptom that frequently gets people their entry into the medical system and into the PT cycle. So a lot of what we're addressing when people come in is back pain, neck pain, shoulder pain, knee pain, headache, what types of things we're addressing. So pain is a huge issue in PT and just in life in general. So pain, the definition of pain, if you want that, is an unpleasant sensation. So it's discomfort caused by stimulation of pain receptors. But it's not necessarily as simple as that. There are other factors. So pain is a biological defense system. It's our body defense system. It warns us there's a problem. It warns us like, it's too hot out here, it's too cold out here, your hand is in the fire. So if you didn't have that warning system, it could cause a lot of problems. There are complex mechanisms determining pain, and many of them are not totally understood. So we, in the clinic where I work, we have a chronic pain education program, and part of what we do is called therapeutic neuroscience education. And basically there is research to indicate that if you teach people about how their nervous system works and processes pain, it can actually help reduce their pain. So it's one of those things, the more you know about it, the better off you are. And as therapists, the more we know about it, the better we can help our patients deal with it. So normally pain is assessed by a subjective scale, and the subjective scales were developed to compare pain levels over time. So you cannot compare one person's pain to another person's pain, but you can compare one person's pain to their pain earlier or later. Okay? So that's what those subjective scales come about. And I'm sure that in 110 this summer, you're learning about how you're going to assess people's pain. A little bit later in this lecture, I'll talk about some alternative pain scales. The classic is, what's your pain on a scale of 0 to 10, 10 being emergency room pain and 0 being nothing. There's a scale that I like that uses that same 0 to 10 pain, but it kind of gives people a little more definition. Like the lower numbers are like you can still do things, but the pain creeps into your consciousness every now and then. 5 is, pain is always there no matter what you do. Higher than 5, usually it's keeping you from doing things. So those subjective scales with a little more definition are sometimes helpful for helping people determine what level they're at. So pain can be caused by lots of different things. Inflammation, which we'll talk about in chapter 5. Infection, ischemia, and tissue necrosis, as in with a heart attack. Stretching of tissue, stretching of tendons, ligaments, and joint capsules. Chemicals, burns, muscle spasms. It can also be caused by no stimulation whatsoever, and basically that is caused by dysfunction of the nervous system. And we'll talk more about pain in modalities next quarter, because we're going to address physical modalities that we do to address pain. And we'll talk about it a lot more in neurology next winter when we talk about the body's pain control mechanisms and the neurological mechanisms of pain. Very interesting. So we're going to classify 2 different types of pain, somatic versus visceral. And basically it's what part of the nervous system are you using to report that pain. So somatic pain is body pain. Soma means body. So the pain is from skin or bone or muscle. It's conducted by sensory fibers. taking the messages from the periphery to the central nervous system. Visceral pain originates in organs, and it's conducted by sympathetic fibers. So visceral pain can be acute or chronic, as well as somatic pain can be as well. So pain pathways are nerve pathways. We have some nerves that are classified as nociceptors, and nociceptors are basically pain receptors. Although they can more accurately be described as danger receptors, they are letting our brain know when our body's in danger. And the nociceptors in our pain pathways are usually free sensory nerve endings. So they may be stimulated by temperature, and it's extremes of temperature. So it's one thing if something's cold, it's another thing if it's cold enough to cause danger to your tissues. Or hot, same thing. Chemicals like acids, bradykinins, histamines, and prostaglandins, those internal chemicals, those can stimulate pain pathways as well, stimulate nociceptors. Physical means like pressure. So a nociceptor is sort of a specialized receptor for things that might hurt you. So you can have pressure that's actually nice pressure that stimulates other nerves. But when the pressure gets so much that there's the threat of tissue damage, that's when the nociceptors are stimulated. So we'll talk about pain threshold versus pain tolerance. So these guys in the cartoon, one of them says to the other, "Don't worry, you'll cross the pain threshold in a couple more years." And he's got a smile on his face. Looks like maybe he's already crossed that. But we're going to define pain threshold differently. So pain threshold is basically the level of stimulation required to elicit a pain response, and it usually does not vary among individuals. So how much pressure do I need to apply in order to go from like, oh, that's pressure, and maybe it feels good, like a trigger point release or deep tissue massage, into the pain range. So that's pain threshold. How much stimulation is going to stimulate those nociceptors and elicit a pain response? Pain tolerance is the person's individual ability to cope with pain. It varies among individuals, and it's often culturally related. That is a fascinating area. When I was an EMT, I worked with this ER doc who, I think he was originally from Minnesota, and he had done his residency in Kentucky. And he said that he felt like there was some sort of cultural barrier between him and these little old ladies that would come in, and they'd say, "Oh, I'm paining real hard today, doc." And he said that he felt like it meant something specific to them, but it was very difficult for him as a young doctor to determine what they were really trying to tell him. So very interesting cultural aspects of pain. So our pain pathways, our nociceptors are stimulated by either thermal, chemical, or physical stimuli. As we talked about earlier, there are different types of nerve endings that are going to transmit those to us. We will talk way more about that in neuro in winter quarter. So there's more detail in the chapter in the book than I'm going to go through right now. But this is sort of your introduction to pain, and then we will talk about it again and again and again. So as I've said before, and we'll probably say again, important concepts, we don't just talk about them once. We talk about them over and over again throughout the program. So our nociceptors, or pain fibers, if you want to call them that, are afferent fibers, meaning they are taking information from the periphery to the central nervous system. We basically have two types that are, you can consider them fast pain fibers and slow pain fibers, or acute pain and chronic pain. So A delta fibers are myelinated, meaning they have the myelin sheath. They're going to transmit impulses very rapidly. They usually transmit acute pain, sudden, sharp, or localized pain. They also transmit things like tickle and itch, so irritating things as well as sharp. So the relatively unmyelinated C fibers, because they're smaller and they're unmyelinated, they transmit impulses rather slowly in comparison to the A deltas. They are major players in chronic pain. So acute pain tends to be sudden, sharp, and localized. You can say, wow, it's right there, point to the spot where it hurts. Chronic pain tends to be more diffuse, dull, burning, or aching. And it has to do with the spinal pathways that it runs in, and we will talk way more about that in neuro. So in tests and measures this summer, when you're doing sensory testing, you're going to talk about dermatomes. The dermatome is an area of skin that's innervated by a specific spinal nerve. And there is a map. You can map the body and say which spinal nerves map to which areas on the body. And you can, the somatosensory cortex in the brain is specifically mapped to the source of pain stimuli. So in the post-central gyrus in the brain is an area in the parietal lobe that's our sensory cortex. And there's a one-to-one mapping of areas in the body to areas in the brain, which I think is super cool. And we will talk about that more in neuro too. So that you can poke one place and light up that place in the brain. Pretty neat. So a reflex response is an efferent response, meaning it's going from the central nervous system out to the periphery. And usually it's not something that goes all the way to the brain to be processed. It happens in the spinal cord. It's an involuntary muscle contraction away from the pain source. So you step on a tack and you withdraw your foot from the tack. Or you touch something hot and you draw your hand away. You don't even have to think about it. It happens so fast in the spinal cord. And it's involuntary. It's an involuntary muscle contraction to guard against injuring that area. So I'll talk just a little bit about pain theory. And the one part we're going to talk about way more aspects of this in neuro. But gate control theory is the basic level. Basically, we have control systems or gates built into our normal pain pathways. And these gates can modify pain stimuli, conduction, and transmission in the spinal cord and brain. So normally this is happening in the dorsal horn of the spinal cord. When the gates are open, the pain impulses can be transmitted from the periphery to the brain. When the gates are closed, it reduces or modifies the passage of pain impulses. So next quarter in modalities, we are going to talk about how do we close the gate. What different physical modalities that we have that have a gating effect that can help change pain transmission. Okay? So here are some of the things that can be used to control pain. Ice. Isn't that nice? Impulses from temperature receptors in other nerves, which are the A betas, and we'll talk more about the A betas next quarter. Those temperature receptors close the gates. TENS, or transcutaneous electrical nerve stimulation, increases sensory stimulation at the site, and it blocks pain transmission. So it blocks it right there at the dorsal horn of the spinal cord. We have endogenous opioids in our system, and they're chemicals that our central nervous system secretes that block conduction of pain impulses to the central nervous system. So it says in the book that they resemble morphine, but I think it's more accurate to say that morphine resembles our endogenous opiates. So we have receptors in our body for those endogenous opiates, and it just so happens that there's a plant out there that produces a molecule, and then we have synthetic versions of that now, that can bind to those receptors that are in there for our natural endogenous opiates. So you'll hear them sometimes called endorphins, but that's kind of the general term. They're enkephalins, dynorphins, and beta lipoproteins that all bind to those opiate receptors in our brain. So that's why opiate pain medications work, because we have those receptors. So if we didn't have receptors for our endogenous opiates, then opiate pain medications wouldn't have any effect on us. It's because we have those receptors that they have the effect that they do. So signs and symptoms and diagnosis of pain, we're going to ask people what's the location of your pain. A lot of times we have the little diagram of the body and they color in, or put X's or whatever where the pain is. We ask them to use descriptive terms such as aching, burning, sharp, throbbing, widespread, cramping, constant, periodic, unbearable, or moderate. So lots of different modifier descriptive terms for pain. The timing, is it associated with a particular activity? Does it come on when you've been standing for a certain amount of time? Or with walking or with sitting? Physical evidence of pain, like paleness and sweating, that usually happens with acute pain. High blood pressure or tachycardia, which is a high heart rate. Those can be physical signs of pain that we see. Nausea and vomiting can occur with acute pain. Fainting and dizziness. Anxiety and fear, really common in people with chest pain or lots of trauma. Clenched fists or rigid faces, and I'm going to talk in a little bit about an alternative pain scale that uses these physical signs to help pin that down. Restlessness or constant motion, or guarding of an area to prevent stimulation of receptors. So this is an alternate pain scale that sometimes is used in an acute care setting. It's called the FLACC scale, FLACC, face, legs, activity, cry, and consolability. So it's an objective pain scale that you can use if a person is unable to quantify their pain. A lot of times they will use it for children who don't understand the idea of a pain scale, or for someone, for whatever reason, they can't talk or they can't quantify their pain. So you're going to look at them and you're going to look at their face. And so if they have no particular expression or they're smiling, they get a 0 on the face part. If they occasional grimace or frown, or if they seem withdrawn or disinterested in what's going on around them, they get a 1. Frequent to constant quivering of chin or clenched jaw, that's a 2. You add up to a scale from 0 to 10. Legs is normal position or relaxed. 1 is uneasy, restless, or tense. And 2 is kicking or legs drawn up. Activity, they're lying quietly in a normal position and they move easily. 1 is they're squirming or shifting back and forth, or they're tense. And 2 is they're arched, rigid, or jerking. Crying, either they're not crying, whether they're awake or asleep. With a score of 1, they're maybe moaning or whimpering or occasionally complaining. And 2, they're crying steadily, screaming, sobbing, or frequent complaints. So I've seen people in the clinic, in outpatient and inpatient, who were definitely a 2 on the crying scale, men and women. They could not hold still. They were in so much pain. They were squirming, shifting, uncomfortable, crying, sobbing, saying, "I can't stand it anymore. Take this pain away." They're very inconsolable. So the consolability is the second C. Either they're content and relaxed for a score of 0. They're reassured by occasional touching, hugging, or being talked to. You can distract them away from their pain. Or they're difficult to console or comfort. So that person with the extreme pain that's crying and whatever, it's very difficult to console them or comfort them. And so they're getting up into that 10 range maybe. So this is a scale that you can use to help quantify the pain when the person is unable to do it themselves. You will get people, though, if you ask them, what's your pain on a scale of 0 to 10? And they'll say, oh, it's 10 out of 10. And they don't have any, on this scale, they don't have any of the pain behaviors, but their pain is real. They're feeling what they're feeling, and it's not up to us to question what they're feeling. You have to accept that a patient's pain is real, and you have to respect their pain. So referred pain, it's pain that's perceived at a sight distance from the source. And sometimes you're not sure what the source is. There are some characteristic patterns from visceral damage in the abdominal organs or a heart attack. Like a lot of times heart attack patients will describe pain going down their left arm. That's more common in men. Women often describe pain in their jaw with a heart attack. There are patterns that are pretty consistent for certain organs, and there's one in the book on page 58, which is pretty good, and then this one here. So it's interesting to, there is a proposed mechanism for that. They talk about that in the book. We're not going to talk about it right now, but we will talk about it in winter quarter in neuro. It's not proven, but it's proposed. Phantom pain usually occurs in adults, and it's more common if in a chronic pain situation. It can follow an amputation. People can get pain, itching, and tingling in the limb that's not there. It doesn't usually respond to common pain therapies. It may resolve on its own. They're not really sure what causes it. There are some theories about it. One of them is the balled up nerve endings in the amputated leg are still mapping to that part of the brain that represents that missing limb. I have had some good success treating people in the clinic after amputations with graded motor imagery and mirror therapy, so there's some interesting new treatments out there, interventions. Pain perception and response is really variable from person to person. So a person's pain tolerance it's going to depend on the degree of pain, the intensity or duration. It may be increased by an endorphin release. It may be reduced because of fatigue or stress, their pain tolerance. So it varies among people in different situations. So everybody's a little bit different on how their pain tolerance is affected. Someone's pain perception, you can't compare one person's pain to another. It's very subjective, but you can compare one person's pain, the same person, from day to day. So an individual's response to pain is highly influenced by personality, emotions, and cultural norms. It's also highly influenced by past experiences with pain. So there's an interesting study that was done with children who participate in contact sports are less likely to develop chronic pain problems as adults. And there's the theory behind that is that in a contact sports situation, pain is almost a desirable effect because you're in there, you're doing your sport, you're part of the team. It's interesting. So there are a lot of different things that can alter pain response. Acute pain is usually sudden, severe, and short-term, and it indicates tissue damage. It can be localized or generalized, and usually there's a physiological stress response that goes with it. Increased blood pressure, increased heart rate, cool, pale, moist skin. It's sympathetic nervous system symptoms, increased respiratory rate, and increased skeletal muscle tension. Vomiting may be present with acute pain. There comes a time in every pathophysiology class when we have to talk about vomiting, and that point is going to come next quarter where we talk more specifically about it. Someone might have a strong emotional response to pain. Chronic pain, it's different from acute pain. It occurs over extended time. It may be recurrent or it may be constant. It's usually more difficult to treat than acute pain, and it's often perceived to be generalized. So acute pain is often in a specific place. Chronic pain is often more generalized. The individual might be fatigued, irritable, and depressed. Sleep disturbances are really common with chronic pain. And I don't know about you, but if my sleep is disturbed, I'm fatigued, irritable, and depressed. So that just feeds into the chronic pain cycle. The specific cause of chronic pain might be less apparent than the cause of acute pain. So acute pain, a lot of times it's tissue trauma, but chronic pain is less specific. It might affect their appetite, and it could lead to weight gain or weight loss. So I found this graphic on a chronic pain website, and I think it's pretty cool. In the therapeutic neuroscience education that we do in our chronic pain program, we talk about parts of your brain being in a pain meeting, so they're not available to do other things for you. And that's sort of what this is like. So you have all these different parts of in the mind of a healthy person, but a chronic pain sufferer, a lot of their resources are being dedicated to the pain, and so they don't have as many resources for these other important things. So this is from the National Institutes of Health and the CDC. More people in the U.S. live with chronic pain than cancer, heart disease, and diabetes combined. More than 30% of Americans are living with some form of chronic or severe pain. So we are going to see this in physical therapy for whatever reason. And also, it's not fair. Someone with chronic pain can also have an acute issue, just like someone with a neurological problem can also have an orthopedic problem. So chronic pain frequently affects daily activities. The person might need to make accommodations or pace their activities. Periods of acute pain can also accompany chronic pain. That's what I was saying. It doesn't, you don't get opted out of anything else. But chronic pain tends to reduce your tolerance to any additional pain. So if half your brain is already in a pain meeting, and then you get an acute incident, it can hurt a lot more than if you didn't have that existing level of chronic pain. So in the book, there is the table on page 59 comparing generally the acute and chronic pain, and it talks about the type of pain, the stimuli, pathways, response, emotion, and treatment. And they say chronic pain is difficult to treat effectively, and it really is, but there are some interventions that we can use to treat it. So headache is a specific type of pain that we'll often see in the clinic, and part of what the PT needs to do at initial evaluation is they need to determine, is this a cervicogenic or is it an orthopedic thing causing the headache? Is it something we can deal with in PT, or does this person need to be referred to another medical practitioner? So if it's an intracranial headache with increased pressure inside the skull, that might be an emergency room visit. If it's a migraine, they might need to visit a neurologist or their primary care physician. If it's a TMJ problem that can cause headaches, they might need to visit a specialist for that. So lots of different things can cause headaches, and some of the things we can deal with in PT and some of them we can't. So a lot of times we will classify headache pain by, is it central? Is it caused by dysfunction or damage to the brain or the spinal cord? Is it neuropathic, caused by trauma or disease involving the peripheral nerves? Is it ischemic, so a sudden loss of blood flow to an organ or tissue? Or cancer-related? Cancer can cause a lot of different pain, either by the advance of the disease, pain associated with treatment, or result of coexisting disease. So, our book isn't directed particularly towards physical therapy. It's directed towards all healthcare practitioners. So it discusses a lot of things. And as physical therapist assistants, we need to know about the medications, even though it is out of the scope of our practice to prescribe or recommend them. We still need to know about them. And a lot of times patients will ask you for recommendations like, oh, well, should I take Aleve or ibuprofen, or should I take, whatever. And at that point we need to say, well, that's a good question for your doctor. It's outside of the scope of my practice to recommend medications. It is good for us to be able to recognize adverse reactions to medications, so then we can refer that person back to their doctor, or call the doctor ourselves and tell them that it's going on. So the idea of using medications to manage pain is to remove the cause of pain as soon as possible. So we have analgesic medications, either orally or by injection or transdermal patch. And then medications are usually classified by ability to relieve mild, moderate, or severe pain. So there's this chart from the book from page 61 that talks about the different types of medications that are used for mild, moderate, and severe pain, and what their potential adverse effects are, and their action. How do they work? So There are other, besides the ones that are listed in that table that are analgesic drugs, there are other drugs that are used in as adjuncts to analgesic therapy. So sedatives and anti-anxiety drugs are included in that category to promote rest and relaxation. And the combination can help reduce dosage requirements for the analgesic. So again, it's up to the doctor or primary care practitioner to decide what is appropriate. So when it comes to something like cancer, a lot of acute care facilities and cancer care facilities have pain teams that work on reducing people's pain, and they have systems in place for changing medications before someone develops a tolerance, that sort of thing. So that's definitely something that you need the medical team to manage. So there's lots of time in the acute care setting, you'll see the patient-controlled analgesia, which is called the PCA. They have an IV line, and this device is attached to it. The patient can press a button, and it's going to give them their pain medication. It usually lessens the overall consumption of narcotics. One of the factors of it is the patient feels more in control and less panicky, and so a lot of times that alone helps reduce their pain. Intractable pain is the descriptor for pain that cannot be controlled with medication. So frequently that type of pain is reliant on surgical intervention. Sometimes people are admitted to the hospital with intractable pain, and they end up with one of these types of surgical interventions. Anesthesia is used to control pain during surgery. So local anesthesia is injected or applied to the skin or mucous membrane. So like when you get a dental procedure and they do the injections, that's local anesthesia. Or if they use a topical anesthetic. So spinal or regional anesthesia blocks pain from the legs or abdomen. The anesthetic is injected into the spinal cord. And frequently these days, spinals are being used more often in surgeries like total knee replacements, total hip replacements. There are less overall side effects from spinals versus general anesthesia. General anesthesia is where you actually have loss of consciousness using inhaled gas or injection. And all of these are applied by a doctor or dentist, or when we get into the spinal in general and the neuroleptic anesthesia, they're applied by an anesthesiologist. So the neuroleptic anesthesia, the patient can respond to commands, but they are relatively unaware of the procedure and have no discomfort. So this is the type of thing that they often give you when you go to get a procedure like a colonoscopy. They can ask you to do stuff and you'll do it, but you don't remember. And this is good because you don't want to remember. So they're just different types of anesthesia that are used for procedures. This is the table from the book that talks about them. Effects and purpose.